My name is Dr. Robert Reilly. I'm a specialist in medical oncology and hematology with the Alliance Cancer Specialists. I went to college at Holy Cross in Worcester, Massachusetts, and graduated from the New York College of Osteopathic Medicine. I did internal medicine at Metropolitan Hospital in Philadelphia and did my fellowship training at Pennsylvania Hospital in Philadelphia. When someone is first diagnosed with breast cancer, one of the first things we look at is the stage of the disease. And we use stage to predict outcome and to predict for the appropriate treatment. Now, in the past, this was always done based solely on the physical findings. Were lymph nodes involved, the size of the tumor, and from that we would then treat people. And we know that there were people we overtreated and there were people we undertreated. So we just treated everyone. Over time, we've learned that the genetics of the cancer can predict for risk independent of stage. So based on the gene pattern, we can determine who has a higher risk and who doesn't have a higher risk. So we can have someone who may have what in the past we would give chemotherapy to. We can do a test. Based on that test result, say, no, you don't need chemotherapy. You just need to go on a hormone pill. Maybe you just need to be observed. Or we can have someone who in the past we would say, your outcome is great, don't worry about it. Meanwhile, we find they have a very high-risk cancer and we should treat them and we can increase their chances of being cured. Now, when I speak of a genetic panel, I don't mean the genes that you've inherited from your mother and your father. What I mean are genes within the cancer, oncogenes or cancer genes, changes in the hard drive within the cancer cell that then make it into a cancer. This is completely different from, for example, a BRCA gene, which you inherit from a parent and can increase your risk of breast cancer. So in this case, we're not talking about risk of developing breast cancer, but risk of developing metastatic disease from breast cancer. These tests that we have, there are several out there on the market. One is called an oncotype test, and in this they use a 16-gene panel. These 16 genes were looked at by the various groups and felt to be predictive of risk, and they went back, looked at old studies that were done, tested people who already knew their outcome, and then applied these genes and saw they were predictive of risk. The other test out there is called the mammoprint test. This is a 70-gene panel, and this came out of Denmark, out of a huge population study. They went back, they looked at their breast cancer patients, tested their genes, and identified 70 genes that predicted for risk. When this is applied to our breast cancer patients who have early stage disease, we can then determine who should receive chemotherapy and who shouldn't. Nothing makes me happier than to see a woman and say, no, you don't need chemotherapy. I think a breast cancer patient should come to Alliance because of our personalized care. When you come in, you don't see a fellow, you don't see a resident, you see me.